Yeah, so my presentation was about the high-risk muscle invasive. I spoke and I gave some summary and guidelines for the future on treating high-risk muscle invasive. That means the perioperative space. So in summary, there are a lot of trials going on using neoadjuvant immunotherapy or combination of immunotherapy, chemotherapy before surgery, or even like radiation therapy and immunotherapy followed by surgery. This was one of the late-breaking abstracts that were presented at this meeting. So the summary, it's interesting to see that there is a high rate of pathologic complete responses whenever you are using either monotherapy with immunotherapy, or even if you are treating in the neoadjuvant setting patients with chemotherapy and immunotherapy. And the point is that what's the best way to approach how to include the immunotherapy in this perioperative space. So then the answer is going to be the phase 3 trials, and presently there are several trials ongoing where different arms of treatment are being compared, mainly the chemoimmunotherapy compared with the chemotherapy that is the standard of care, and sometimes even with monotherapy with immunotherapy. So these trials obviously are going to give us some answers about what's the best approach. We know that the standard of care on the neoadjuvant setting is to give chemotherapy, platinum-based chemotherapy. So the control arm in all these trials is the platinum-based therapy. The other space that was discussed is the area of adjuvant treatment, mainly with immunotherapy after patients are having high-risk surgical resection of bladder cancer. So we know that nowadays, based on the Checkmate 274, Nivolumab is approved in the US and in Europe to give in patients that are having still persisting disease after having received neoadjuvant or unable to receive neoadjuvant chemotherapy, and there is an improvement in disease-free survival. We are still waiting for the overall survival results of this trial using Nivolumab in this adjuvant setting. And also I present the data of the IMvigor010 that this trial used Atezolizumab, and I was the PI of this trial. This trial unfortunately was negative. However, we learn a lot from this negative trial because we use biomarkers. We use the ctDNA just to see if this was any correlation with patient outcome. We describe, and this was published later on in Nature, that high levels of circulating DNA is a marker of poor prognosis. But what we saw in this retrospective analysis from the IMvigor010 is that patients that receive Atezolizumab immunotherapy, they did better whenever the ctDNA was present. And finally, I did present some data on the future on bladder preservation. And now there are attempts just to even only use chemotherapy in selected biomarker patients using chemotherapy or chemoimmunotherapy. And in those that get a good response, we might be able to preserve the bladder. The main trials that are ongoing are the trials that are using the standard, that is chemo radiation therapy plus immunotherapy versus radiation therapy plus chemotherapy. So there is an ongoing trial with Atezolizumab that is approaching the patients giving without trying to spare the surgery, right? So using radiation therapy or chemoradiation therapy plus Atezolizumab or without Atezolizumab. So these phase 3 trials are likely to solve the answer if adding immunotherapy in bladder preservation is the way to go.